blended learning platform that brings together the WASH and health communities to focus on policy, evidence, and practice in WASH and healthcare facilities. Our goal is to connect the expertise and experience of our partners and colleagues to the members of the WASH and health community who have expressed interest in taking action in WASH and healthcare facilities. We've created this platform as well as our newsletter, which many of you receive, and our webpage to share resources with the WASH and health community. And our goal for each session is that participants walk away with tangible information that will allow you to take the most immediate steps to advance the improvement of WASH and healthcare facilities. What can you do today or tomorrow? So hopefully we'll get some of that even today as we start thinking about what really is the definition of success for WASH and healthcare facilities, and what are some of those indicators that many of you may even start using very soon. I also want to remind everyone of the guiding principles of this community of practice. So you know where we are coming from in these webinars, or when you see our newsletter or some of the resources that we put out. We believe wholeheartedly that WASH is a fundamental prerequisite for quality care within a healthcare facility, and therefore there cannot be effective infection prevention and control without adequate WASH. We also believe that WASH in healthcare facilities is a solvable issue, but it will require multiple systems, stakeholders, sectors that have to work together to see sustainable improvements. We also, as a community of practice, are open to all who seek to learn and share about WASH in healthcare facilities, so that we respect and we are really inviting the diversity of perspectives that are within our communities in order to make the work possible. Every time we get together, we try to celebrate, and one of the ways that we do that is we highlight some trainings, and I see Lindsay. You can tell us what these trainings become clear, but one of the things that I know many of you are aware of is that over the past several months, there have been multiple WASH-Fit trainings taking place in multiple regions in Mozambique, Benin, Bangladesh, South Africa, Venezuela, and Lindsay will tell us what has become clear from some
Clearly was a little bit multitasking yesterday. No, so I was actually participating in one of these trainings in Bangladesh, which was a regional training. And for me, it became clear that WASH-Fit has become much more integrated into the countries. This is a very, people are very aware of the tool. This is not the first time people are hearing about it. And now it's really scaling up and really using this in multiple, more facilities throughout governments. And really getting the government backing behind it. So it was really exciting to see compared to 2 or 3 years ago, where this was a new concept and people were just learning about it. But people are ready to really jump in fully behind WASH-Fit. But please, if you have experienced a WASH-Fit training recently, put in the chat where you were trained and the kind of work that you all have been doing. And next time I will fully fill out my slide.
No worries. Thank you so much, Lindsay. And again, go ahead and put in the chat if you've been already participating in WASH-Fit trainings and exactly where, because that would be helpful and useful for us to know. Some other information for you. There's some new resources from the community of practice. So we have updated a literature review that I believe we started in 2019, I believe. It has been, again, reviewed, and we have now 85 journal articles on WASH in healthcare facilities. Again, for those who have been searching the literature, trying to find and understand where the gaps might be or what exists in terms of studies, research, best practices. This list is probably the most comprehensive that we have been able to come up with, and we have made that available to you, I believe, on our website. Also, many of you are already aware, but we do have summary videos for some of these webinar live sessions that are a bit shorter than the hour and a half that we spend together, and really kind of summarize what it is that are the themes and big topics that we've covered in each session. And so those are available in English, French, and Spanish, and those are found on our YouTube channel, which is the address here. I think you can just put that in YouTube and you'll be able to find our channel and look at our previous videos. We also post the entire meeting also on YouTube and on our website. So please take a look at some of these resources as needed. So I'm going to switch over now to talking about this issue of success and what we're doing here, and spend a few moments framing out sort of why we have undertaken the process of creating this workshop. And then I'm going to pass it on to 2 of our steering committee members who are going to share some of their experiences with measuring success and indicators. So Many of you are already aware we've had a recent report from the JMP entitled Progress on Washington Healthcare Facilities 2000 to 2021, which had a special focus on WASH and infection prevention and control. And it basically presented new data that was released in August 2022, covering over 900,000 healthcare facilities. And so with that data, we now have an even more clear picture of what's happening in healthcare facilities. We know that 1 in 5 lack basic water services, 1 in 2 lack basic hygiene services. Again, this is the first time we're seeing global estimates for hand hygiene. And then 1 in 10 lack any sanitation services. So given the extent of these challenges, we can imagine that many individuals and organizations have launched into detailed assessment work to inform programming to address these major gaps. And some of you may have already started this or be in the process of conducting assessments. Baseline assessments have become very common among a variety of groups as more refined tools are becoming more available. We just talked about WASH Fit and the many trainings that are going on. Emory has worked on this in terms of a WASH Con tool. We have other updates that we've seen, especially with WASH Fit, to include issues such as climate and equity. We have FACET, again, a number of tools we're using. Yet, as we're moving forward with assessments and more initiatives are being launched, the discussion on how we evaluate this work has really lagged behind. So the default is that program designers are using the JMP indicators or WASH Fit indicators or other descriptive indicators on conditions, service availability to try to get a sense of what is success. Now, this is not necessarily wrong in theory because the constructs that many of these indicators measure are very useful for us to understand in terms of access, functionality, and usage. However, many of these indicators are really not designed to evaluate programs. And if they are used, they represent the bare minimum of what we may need to be looking at in terms of evaluating our success. Now, on the opposite end of things are the very intriguing but difficult discussions around health impact studies for WASH and healthcare facilities, meaning to what extent, if any, do we see WASH improvements having a direct causal link to changes in health status of a given target population? That's a really great question, but it's really difficult to measure. So there has to be something in between, right? Something that we can hopefully together in this workshop understand to help us get at some of these possible indicators and figure out a way to really start defining success. So in order to increase prioritization as well as drive investment in Washington healthcare facilities, we have to be able to demonstrate success of these programs beyond increasing access, right, to basic WASH services. So today, in order for us to demonstrate that success, we have to identify what are those indicators that we're going to use. And I'm just going to spend a few minutes just talking about defining success, just for some of us who have worked on this, if you're in evaluation kinds of work, if you are an M&E person, or even if you are not. The two really main issues I want us to all keep in mind is that to determine how, basically in order for us to determine how we're going to measure this success, we have to focus on what aspects, what are the concepts, what constructs are we really trying to measure, and really who is defining the success? Because you can imagine as the different stakeholders shift, people are going to have different priorities, which means that we'll have a variety of ways of defining success. And we have some examples here in terms of what we could potentially measure. So we can measure issues of safety of healthcare facilities, whether the facility is meeting standards and guidelines, whether adherence is something of interest, or if you have particular program or project goals that you're trying to meet, are those indicators what you're using? And again, depending on who's measuring it, it will determine what we define and what we present as successful, right? So we know these nuances are sort of embedded in this entire workshop. So we just want you to keep that in mind. So now I'm going to pass it on to two of our Washington Healthcare Facilities steering committee members. We'll start with the first. This is Ms. Hadra Mukasa, who's from AMREF Health Africa. And Hadra, I believe I saw you come on. Hopefully you can hear us. Yes?
Yes, yes, I can hear you.
Perfect.
I just hope that my internet behaves. The internet has a way of misbehaving when you need it the most.
Okay, well, I'm going to go ahead and pass it over to you to talk through some of your experiences with trying to define success and identifying indicators. So over to you.
Thank you very much. My name is Kampata Jamoksa. I work for South Africa and Uganda. So our AMREF, given the main purpose of the existence is creating a lasting health change in Africa. So our desire was to create the lasting health change, but using WASH to improve indicators such as morbidity.
Roger, we're having a hard time hearing you. Hopefully you can hear us. Your voice has faded out. Hadra, do you need to come back in? Okay, maybe, Lindsay, as we help Hadra sort out the sound, maybe we can move over to Laxman.
Yep, that sounds great.
Okay, great. So what I'll do is, if you all can close your eyes really quick, I'm going to advance and move over to our other steering committee member, Laxman Chetri from Terze Om, Nepal. Hopefully, Laxman, you can hear us.
Yes, thank you. I can hear you. And okay, if I can continue.
Yes,
I
absolutely.
begin with welcoming all to this presentation of Terze Om. This is on the indicators we have chosen for the evaluation of effectiveness of implementation of WAS in healthcare facility program. Next slide, please. Yeah, the proposed indicators are the outcome from an exercise on development of policy on operation and maintenance of WAS in healthcare facility in the Thakur Baba municipality of Nepal. In this, we had chosen indicators for monitoring the performance of the policy. One, it will be brought into implementation in 2023. We also carried out total costing under this. We had made a brief presentation about this costing exercise during our April webinar. Next slide, please. Yeah. These are the chosen three groups of indicators. The first is on coverage and quality or access, as Johanna told earlier. This uses indicators from JMP and WASFIT. These are what we have been generally doing so far in the sector. The additional indicators are on functionality and uses. These are indirectly related to impact evaluation, as proxy indicators of impact, we may call. As we'll see that in the next slide. But let me come to how we have defined functionality. We have defined functionality of any WAS facility. It could be services also. Is the percent of days or time functional to the total expected functional time, which will be 365 days on a yearly basis. Similarly, uses have been defined as the percent of time in use out of the total expected functional time. And for a well-functioning system, it should be used by all the sections of the users of all age, sex, socioeconomic status, and abilities. Yeah, we can move to the last slide now. It's a very brief presentation. Yeah, here we are showing the basis for adoption of functionality and uses of facilities as the proxy indicators of impact. It is based on WSO's minimum evaluation procedure. I have given here the reference. It says SOs in the impact causal chain that are in bold with 3 arrows, where the facilities are functional and in use, impact are obvious. It will thus suffice and be more relevant to carry out assessment at the functionality and uses levels. Because on the one hand, carrying out assessment at the impact level that are done through epidemiological studies is costly and methodologically difficult. And at the same time, it is also not necessary at the project level, implementation level, as studies have already established this causal link that where facilities are functional and in use, impacts on health are obvious. So it will suffice to carry out the assessment at functionality and use levels. Now, this is all about my presentation. So if there are any.
Thank you so
Yeah.
much, Laxman.
Thank you.
And again, this is an opportunity for us to hear what some of our partners and others are doing on the field as it relates to indicators and again, this issue of defining success. And Laxman, thank you for taking us through some of the work that your group is doing. If anyone has particular questions for Laxman, go ahead and put in the chat. But let me move over back to Hadra. I believe we do have her back on. Hadra, can you hear us now?
Hadra, if you can hear us, you're still muted. It looks like she has jumped off again, Joanne, unfortunately.
Okay. Okay, so what we can do is, and I've done this before, I've presented some of Hadra's work before on her behalf at the UNC conference. What we can do is just walk through some of the components of this presentation. And if she comes back on, Lindsay, let me know. I'd be happy to pass it over. But basically, this was
Yes, I am on.
there she is.
I am-
Perfect, Hadra. Go ahead.
Okay, so just to make sure I let me go through first before I drop off. So we wanted to look at our indicators focus so much on uptake of maternal reproductive health and newborn care services as an indicator of improvement in services that would eventually contribute to reduction of morbidity in sepsis amongst mothers and neonates. And so, but what we first did was to do an assessment in all the healthcare facilities providing services, healthcare facility services, basically curated services. And the trigger was what we saw on ground. Like you see on the extreme right, you see at one of our visits to these healthcare facilities, we found a pig having a bath in a bath shelter that a mother was supposed to use after delivery. So for us, that gave us what we needed to do. We then thought that Washington Healthcare Facility had to go beyond just looking at infection prevention and using services that mean supplies and products, but also to go up to the level of revamping the status of WASH in healthcare facilities, including providing services that were lacking. And also, none of these healthcare facilities had running water. For us, that was really a big deal because then pregnant mothers had to fetch water and come with their own water. And or if you had a caretaker, they had to go outside of the healthcare facility to bring water. But also, there were no latrine services. Most of the healthcare providers told us that they had to hold on and not use the bathroom until they went back home because they didn't want to share latrine facilities with patients and all community members. And also, because there was no water, hand washing practices were really bad, both amongst the healthcare workers and the caretakers of the patient. Another thing that we saw is that the incidence of sepsis was really high, especially amongst children of 28 days and below. So with those things that we saw, our intervention purpose to try and contribute to changing the indicators. Next slide. And so we took on a holistic approach where we did both software, training the healthcare workers, how to, on soft skills, customer care, because during the surveys, some mothers told us in addition to having poor healthcare facility conditions, they also said the health workers were not friendly, but then you couldn't blame the health workers. If I've come for work and I don't even have a good toilet to go to, and I have to hold my urine the whole day until I went back home, then maybe I'll be unhappy because I'm stressed and I'm not healthy, I'm not emotionally okay. And so we did both software. We also provided the supplies and products to just keep basic cleaning, but we decided to revamp. Our target was the maternity rooms, the sluice rooms, and also the care of healthcare waste, where we looked at placenta pits, provision of latrine facilities for patients to avoid the sharing of latrine facilities. But our focus was providing services that are sustainable. So we looked at drainable pit latrines and waterborne latrines. but also what we did with all this intervention in place, we focused on 3 impactable indicators. And this helped us to collect data on a quarterly basis because we wanted to monitor to see if we're even progressing at all and see if we had to do something to change. And then we made sure to link this data with the district information, the district health management information system, so that we are not collecting data that would contradict with what the district was collecting. Then 4 years down the road, in addition to the quarterly data collection that we were doing, we realized some changes, and there was reduction in the proportion of
Hadra, we've lost your sound again. I'm not sure if you can hear us. Okay, it looks like we've lost Hadra's sound. Okay, so in the interest of time, and because I know it's difficult to maintain this connection, I think we all can see where Hadra was in the presentation in terms of the impact that they have witnessed from the intervention, not only the decrease in sepsis rates in neonates, they also saw skilled delivery in healthcare facilities increasing from 20% to 92% by the 4th year, which is an excellent change that they noted. And then increase in the service satisfaction levels among the mothers, the quality of the services improving from 64.1% to 93%, which is an interesting indicator in terms of that satisfaction, which you all may want to think about or talk about when you start thinking about success of some of your programming. So I believe that was the end of Hadra's section. And so again, I'm so sorry that we weren't able to hear all of what you wanted to share with us, Hadra, but hopefully if you are in the chat or able to reconnect, please go ahead and put any additional comments or thoughts you have about some of the work that you've been doing. And if people have questions for Hadra, please go ahead and place those in the chat as well. And I'm sure she'll be able to see and potentially respond. So now I'm going to move past some of the examples and hand it over to Lindsay, who'll talk about what we're going to do in the next half of this session. Lindsay?
Sure. We have a few extra minutes though, and I see some comments in the chat. So maybe I'll pose them to particularly Laxman, because I think you have connectivity, Laxman. There's 2 questions here. One from Martin Wasisi asking about functionality of 365 days. And does it provide at minimum number of days of system maintenance? And then we've got a second question here from Olfemi about coverage and quality indicators. Is there a synergy in ratings between JMP and WashFit, which I can come back to? But Laxman, do you want to come in on Martin's question?
Yes, thank you. I've written down in the text also. Yeah, this JMP are more, they indicate the excess availability, but WashFit indicators go more deeper that permit us even development of the WAS improvement plan. So these are the differences. But we have been so far using both. But when you see in WASFit 2, there's an attempt, the JMP indicators have also been put together. This message I've also written down in the chat. I hope if this, does this answer?
This answers the first question. Fantastic. And there's a second question though for you about maintenance and assisted maintenance.
Yeah, 365 days is the ideal for calculation. But when you make the target, definitely target would be, I would suggest if we can keep 90% or more than that, that will be good target. That is for the purpose of calculation. Is that clear? If we are calculating what is the functionality, then we take the figure of, we can take 365 days. But when you keep our exact target, that has to be definitely less than 100%.
Fantastic. Martin, if there's further clarification that you're interested in, please put in the chat and you and Laxman can go back and forth. And thank you, Laxman, for responding here. Similar to your comment about the JMP and WashFit, there is synergy between them. There is more detail, as Laxman said, in the WashFit scoring, but there you should be able to calculate your JMP score from doing a WashFit assessment. So fantastic. Any other questions for our presenters? Great. Well, if anyone has any further thoughts, please feel free to put in the chat. These are two examples. We had during the UNC conference 3 or 4 other presentations that shared examples of their work. So it's very helpful to hear that there are organizations who have been starting to assess and evaluate their program success and have had different approaches. If you've heard from Laxman and Hadra, they took very different approaches to look at how their program was working. And so as we think about an evaluation framework, Joanne and I and Haley put together this very basic approach here to evaluation. It may not be the one that you use at your organization, but this was one to help structure our conversation today. And you look at it, there are 3 levels at which you would be attempting to evaluate. The bottom level is activities. This is process and tasks. This is maybe would say probably the most straightforward, might be the easiest to collect this information. But what did you deliver? Was it consistently functional? Did everyone use your product? Was everyone trained? These are very activity-based and would be very specific to your project. The next level would be looking at outcome or the purpose of program. Did the expectations of change following your particular project or program take place? So was there a change in behavior, for example, around hand hygiene? That's really looking at the outcome that you were seeking through your program. Then the highest level is where we often want to talk about, but we know can be sometimes the most difficult. And so this is going to be looking at impact. This is the broader public health impact we're talking about here. And this will look at what your program may contribute to. For example, better health, increased funding, increased access to services. So if we talk about better health, it might be the reduction of infection in healthcare facilities due to access to clean water, access to safe sanitation services. We know this is the most difficult, particularly in a WASH setting. If you're familiar with other WASH health impact studies in other contexts, it can be difficult to go from the availability of services into a causation that this availability of WASH is actually contributing to better health outcomes. So this is difficult. It is often the thing that donors want to hear. They want to know that they are saving babies' lives, but it's the hardest for us to prove. So it's not to say that we need these. There is a lot of work to be done and demonstration of success from activities and outcomes. But I do think it's worth having a conversation here as we look at all 3 levels around how do we demonstrate that the programs we are doing are successful and therefore should be further invested in, that we can get greater prioritization of WASH. We need to be better at advocating for ourselves, as we know WASH is often underfunded in healthcare settings. And so how through these the measurement of the work we're already doing, can we demonstrate this success? And Joanne, I don't know if I have one more slide here. Great. So if you have here a description of what kind of the 3 different levels, we would actually develop types of indicators. And so for the purposes of today's activity, the idea isn't to come up with the most perfect indicator. That is often a lot of wordsmithing, making sure that we have the right approach to it. Today is about throwing ideas out there to see what would work, what maybe you've tried or you would have liked to try, and brainstorm ideas around what could be successful. So many of you may have examples of activities and processes, and some of you may be working or thinking about the outcome and the impact level. But what we'll do in breakout groups is have a discussion to think about where we are and where we'd like to go. One example of something that I'm really interested in is work that the Clean Clinic approach has done. And they were in the sites where they were working, they looked at the revenue of the facility from the start of the program to the end of the program. And they found that in some of their facilities, the revenue tripled by doing this clean clinic approach over the 8-month period. I think that's really interesting, and that could be really powerful information for a facility director who's very concerned about running a self-sufficient facility based on user fees. Similarly, uptake of patient services might be something that the health facility is interested in. So as we talk about these indicators, it's helpful to think about not only what we're interested in, but who are the people who might be measuring the success? Is it the donor? Is it the service users, the patients themselves? Is it the healthcare worker? What looks like success to them? And so I think it's really valuable for us to take a moment as we go through this and take it from different perspectives. So we're going to get into breakout groups, and we will go ahead and give you probably about 45 minutes to discuss in your groups. And then you'll have a chance to come back. We'll have a quick rundown of what we'll do with next steps, and how we'll compile a full list of indicators based on these brainstorms from today and from the UNC conference back in October, and share those with the community practice. So this isn't just a brainstorming exercise for you, it's actually going to go into a larger list that will then disseminate throughout the community. So we'll talk about that at the very end, as well as other opportunities and next steps. But if you all could take a moment for me, we're going to switch here to the breakout groups. We can, in a moment, we'll be able to stop the interpretation. But first, if you were planning to do the breakout group but speak Spanish, could you please raise your hand? Okay. If anyone would be doing the breakout group in French, could you please raise your hand? Okay, great. All right, I will move you both over. Thank you very much. All right, let me just quickly update that. And then we will go ahead and
We have a third person.
third one. Okay, let me all move you over. I've just got to find you all. We've got Hassan. All right, I will move you guys to the French room so that you will be able to be together. Great. So there'll be no interpretation in the breakout rooms, but you should be with folks that speak your language. So hopefully that will be no problem there. Wonderful. So I'm going to go ahead and open the breakout rooms. If you have any questions, I'll be bouncing around to the different rooms. But the goal of this conversation is to put out there thoughts on how you would evaluate programs, thoughts on what you would like to see evaluated that you think you haven't tried, and maybe some examples of what you have tried. So I'm going to open the rooms, and like I said, you have 45 minutes, and we'll be going around to help you support that. So you should be able to see something that says join on your screen.